I'm going to pass it on to Barbara Moskowitz, who is our moderator tonight, and she is also the Caregiver Support Programs Associate Director, and I'll pass it on to her. Thanks,
Thank you.
Barbara.
Thank you, Judy. And my other wonderful colleagues are here tonight. Our director, Susan Rowlett, my colleague, social work, Chris White. Judy is our senior manager. Nori, who many of you know, is not here tonight, but is always here. So welcome, everybody. I hope you had a chance to enjoy the remarkable weather today. And it's actually an interesting 1-year anniversary for us as a program. It was a year ago this month that we had our first Zoom seminar, which was the official beginning of what has been a very, very, very difficult year for all of us. But it's been wonderful for me, and I think all of us, to know that Zoom has enabled us to continue to meet with you and connect with you and provide support, and we've been able to gather. So welcome tonight, and we look forward to programs throughout the year and in the future. As you know, the Dementia, the Caregiver Support Program of the Dementia Care Collaborative was started at Mass General in 2017, and we are part of the Division of Palliative Care and Geriatric Medicine. And as I know many of you know, the mission of our program is to transform memory care, nothing less than that. We exist at Mass General to educate, connect, and support patients, caregivers, and clinicians. We offer care consultations to caregivers and patients in specific Mass General clinics, skills classes for caregivers, support groups, and health and resiliency program. The Caregiver Support Program is entirely funded by philanthropy, and if you're interested in learning how to support our program, please reach out to any one of our team members. And so now it's my enormous pleasure to introduce our speaker, Dr. Julia Gallagher. Dr. Gallagher is the medical director of the Mass General Brigham home-based palliative care program, and she joined the Division of Palliative Care and Geriatric Medicine in 2014 to develop the program, and it's now large and wonderful, and you'll learn all about it. We're thrilled. Prior to joining Mass General, Dr. Gallagher was a member of the Divisions of Palliative Care and Hospital Medicine at UMass Memorial Medical Center. She served on the inpatient palliative care consult team as a senior ward attending hospitalist and as the hospice medical director for UMass Memorial Home Health and Hospice. So my final comment is those are her remarkable resume items, but I think, as many of you already know, the most remarkable aspect of Dr. Gallagher is her magnificent compassion and spirit and soul. And I am delighted that you're all going to be with her tonight. Thank you, Dr. Gallagher.
Geez, Barbara, thank you so much. Always so gracious. Barbara and I are actually suite mates in the office, socially distanced. And so it's always a joy to still be able to kibitz with her over the coffee maker, shall we say. So thank you so much for inviting me. And thank you so much to everyone for taking the time out of your day, to be here. And hopefully I can provide some clarity to what is often sort of a challenging topic, sort of thinking about best supportive care across the continuum of the illness of dementia. So even though we're a year into Zoom, we have encountered some, or at least I have, some challenges with sharing my slides tonight. So I'll be relying on Judy to keep me moving. So thank you, Judy. So if you can advance me once. So I have nothing to disclose, no financial disclosures. What I hope to accomplish tonight is really to review the differences between palliative care and hospice, sort of how they are alike, but more importantly, how they are different and how that's important. How both palliative care and hospice can really help support a patient and family. And I think we should stress that the unit of care is the patient and his or her family across the trajectory of illness. and really to briefly at the end review what we understand are the expected clinical changes and symptoms that occur in late stage dementia, and how we can use those as signposts to really think about transitioning to either hospice or best supportive care at home. Judy, you want to move me? And so we begin. So I always begin talks like this with really trying to clarify what palliative care is and what it isn't. And so I think of palliative care, it's really the ultimate clinical team sport. It is an approach to care of people living with advanced serious illness. And it's really focused on providing relief from the symptoms as well as stress of serious illness. And more importantly, the goal is to do both of those things to improve the quality of life for both the individual with the disease as well as the unit of care, the family, however that person defines their family unit. Judy? And so as an interdisciplinary clinical team, we really need to focus on what we call the multiple domains of suffering. And this is true for heart failure. This is true for advanced interstitial lung disease or emphysema. And it is particularly true for patients and families who are struggling with dementia. And the reason why is these domains of suffering are the physical, obviously the physical manifestations of dementia as the disease progresses, but also really the profound psychosocial and spiritual challenges that not only the individual with dementia, but the family needs to manage along the course of that illness, right? And it can be a very extensive period of illness, and those needs will wax and wane across that trajectory. And in some months and some years, the domain of suffering will be spiritual. In some months and some years, the primary suffering will be physical. But I think it's really important to understand that really being attentive to all the burden of illness in each of these domains of suffering is really important for the comprehensive care of both the individual and patient. Judy? And so this is a slide I have to say I use probably in almost every conversation I have, every talk I give, is really how do we distinguish between palliative care and hospice? So they're incredibly intertwined. It's like a DNA double helix, and yet they're actually can be very distinct. So I think of palliative care as really the larger of these two circles. That's a clinical interdisciplinary care team based on need. And it's need in any one of those domains of suffering we talked about. And so it's huge. It's based on need, and it's based on who in the care team will help address those needs best. Hospice is really the much smaller circle that sits within palliative care, but hospice is specifically an insurance benefit based on prognosis, right? So hospice does provide palliative care to the extent of the definition we talked about earlier, but hospice is really an insurance benefit that defines palliative care for those individuals that have a prognosis of less than 6 months. And so I think visualizing that can sometimes be helpful because that palliative care sphere of care is huge and really can be provided anywhere along the trajectory of illness. Judy? And so when we look at that trajectory of illness, and it can be a very prolonged trajectory, and at the same time, when people change suddenly, it can feel very abrupt, some of these clinical changes. But I really break it out into three predominant areas that we can think about. The first one is at the time of diagnosis, which can often be a very emotionally fraught time where the burden of illness, at least from a medical perspective, isn't high. People are still able to function fairly independently. There may be warning signs, but this is the time when it's important to start planning. while people are feeling well, while they can actively engage, and really starting to focus on what we call the serious illness conversation, which happens along the trajectory of illness, really focusing on what matters most to the individual with the illness, but also as part of the family unit. What are they hoping for? What are they worried about? So this first part, while people are still feeling well, functioning fairly well, is a planning stage. As the disease progresses, one goes through, which can make it incredibly challenging, this waxing and waning clinical trajectory, where the planning that has initiated at point A really has to be adjusted and then executed along that trajectory, continuing to focus on what matters most, but really, how do we react in these moments of decline when health worsens? Because we will have planned for it, even though it feels sudden, it won't feel like a crisis because we have planned for it. And then as the disease progresses, we enter more of a late stage in the disease. And how do we think about that transition to hospice or best supportive care in the home if prognosticating when death will occur is a challenge? So if you take nothing else from this talk, kind of those 3 slides are exceedingly important in terms of thinking about the difference between hospice and palliative care, the interdisciplinary team, and then this concept of transitioning from A to B to C. And people are probably enjoying my dog right now. So I apologize for him wanting to chime in. And so when we think about planning, it's stage A. Like, how do we think about who is your interdisciplinary palliative care team? And so planning while feeling well, in my mind, really focuses on these conversations about what matters most. What are you hoping for? What are you worried about? And it really becomes very important while people can actively participate in this stage of the disease, if nothing else, to be sure everyone has a healthcare proxy in place. Frankly, when I talk about planning ahead, I actually think everyone who's over the age of 18 needs to have a healthcare proxy, right? And so when people, this is sort of planning through life. Healthcare proxies at age 18, because our families are complex and blended, and the obvious surrogate decision maker may not be obvious, to the healthcare provider. But healthcare proxies, financial or estate planning is important in this phase. And then exploring options for medical management, along the way. How do we think about when health gets worse? And so who do we include on that palliative care team? Because I think of these interdisciplinary teams as all palliative care teams. This may be primary palliative care by your primary care physician, by your neurologist, by a geriatric care manager, but they are all part of your palliative care team. And so who helps you during this planning stage? Family, close friends, community resources, social workers, certainly your primary care doc and neurologist. For those that are lucky enough to have the memory care initiative team and have our nurse practitioner and social worker and our dementia care group, there are huge resources that can be very helpful. Judy? And then as time goes on, the waxing and waning nature of this illness starts to kick in, at least the physical component. I think of dementia as really almost the poster child of truly the suffering in multiple domains. The physical changes that take place is this waxing and waning decline, but all along the way, there are so many needs in the psychosocial, spiritual, and emotional domains of suffering that we really cannot neglect that, either for the individual with the illness or the patient and family. So again, here, as we talked about, stage B is really about executing and adjusting that plan of care that we started to develop in stage A. So as one's physical health worsens, and perhaps even emotional health, conversations again continue about what matters most. And what do we understand about these expected clinical complications and planning for them? And with each of these dips in that graph, that's probably a hospitalization for something that's not unexpected for the disease. And so how do we align quality of life and what matters most with the interventions that happened at each of those hospitalizations? How do we think about maximizing care at home? How do we think about maximizing care in the hospital? And how do we think about maximizing care at rehab with being sensitive to the fact that this individual is suffering with the progression of their dementia? And so at these junctures, there may be increasing reliance on shared decision-making, increased involvement by your healthcare proxy to help voice what the individual would say if they were able to make those decisions in the moment. Again, a primary care doc who knows the individual well, neurologist, and then the hospitalist who steps in at each of these episodes of care, but who really needs to understand what the patient's hopes and worries are, so that hospitalist can work with the other providers on the care team to really put together the best plan of care for the patient following the episode of hospitalization. And this may be where home health providers, home health nurses, physical therapists, occupational therapists, perhaps a home-based palliative care nurse practitioner and care team become involved in your care. Judy? And then what is both physically and emotionally in some ways unique to dementia, and which makes it, I think, one of the most challenging illnesses, both for the patient and the family to struggle through, is that this time spent in the advanced late stages of disease can be very long. And I think both for the family and caregivers, it can be wrenching. And for the individual who often will have moments of lucidity, it can be devastating for them as well. And I think we need to really be mindful and attend to some of those psychosocial and spiritual moments of distress, as well as managing the physical. So again, this period of decline can be variable. There are incredible challenges related to prognostication with the illness of dementia and predicting the timing of death. I think that's one of the things many of the families I help to care for struggle with, is if they only knew, it would be incredibly helpful for their planning. This emotional waxing and waning, some days are still, filled with joy, and other days are becoming more challenging. And I think it's the emotional exhaustion that can be challenging during this late stage of the disease. And in particular for the surrogate decision makers, the healthcare proxies who the individual has identified as that person who can best voice their hopes and worries, these healthcare proxies will often struggle with what they feel is the weight of decision making. And I often try to reassure them that they are not making the healthcare decisions. They are sharing with us the hopes and worries of their loved one and what their loved one would tell us if they were here. Because that oftentimes for healthcare proxies can feel incredibly burdensome. And again, understanding what matters most. So in terms of the hospice Medicare benefit, this is sort of the nuts and bolts of things that unfortunately trip a lot of people up at this stage of the illness. And I know Barbara and I have had multiple conversations by the coffee machine in our office about the challenges of, well, what does hospice mean? Oh, it's an insurance benefit. How does that work? All those logistical questions that are just exhausting to try to think about as you're trying to care for people. And so the hospice benefit is literally that. It's an insurance benefit. It's it's a piece of legislation written in 1982, a little out of date for some of our illnesses and how we care for people. But it's a piece of legislation that created the Medicare insurance benefit that most insurances mirror themselves on, that requires people to have a prognosis of less than 6 months if the disease continues to run its course to be able to access that benefit. And what are some of the expected clinical complications of the illness that whomever from the hospice agency is going to be looking for? Are many times with late stage disease, people will have weight loss. People will have difficulty swallowing. People will be dependent for most of their care on a caregiver. They will have multiple infections, oftentimes pneumonia. And they will have recurrent fevers requiring antibiotics. So those are some of the signposts that really will trigger the conversation towards, can this individual access their Medicare benefit, which actually provides much more comprehensive support also for the caregiver at the same time. The thing about hospice is hospice will also provide hospice care wherever that person calls home. So hospice can be in that, the hospice team, the nurses, the social workers, the chaplains, the home health aides, can provide care in that individual's home to supplement whatever care they have already in place. It can be provided at assisted livings, although assisted livings do present occasional challenges. Nursing homes. Some hospice agencies will own their own hospice residence or a hospice house that an individual can access for three different things under that hospice benefit. There are a lot of details involved with that, but I think two specifically that are important. One is this respite level of care, where they can go for 5 days. If perhaps a caregiver has to go to a graduation, say of a grandchild, or a caregiver has to have their own series of medical appointments. So it provides a 5-day respite care at the hospice house. And if a patient's family for a longer period of time is unable to care for that patient at home, they're able to transition to many of these hospice houses for the ongoing routine level of care. Unfortunately, the way the hospice benefit is structured is that the room and board for that transition would have to be paid for by the family. So there's still multiple barriers to care in certain care settings. Judy? And so, because it's very difficult to anticipate that the timing of the transition to hospice, Judy's telling me to hurry up, I think. How, if it is difficult to prognosticate around the transition of care to hospice, how do we provide hospice-like palliative care leading up to that moment when it might become more clear? And so one can put together a plan of care for best supportive care to that individual outside of the hospice benefit, although the hospice benefit allows you to access much more comprehensive care with home health aides, chaplains, 24-hour nurse availability should something happen in the middle of the night. But I think what I see in terms of providing this sort of gray zone palliative, more like hospice care, is really saying we want to maximize care in wherever the patient is living as best we can, and really working closely with our primary care colleagues or our geriatric colleagues who are most comfortable in managing this probably now homebound individual over the phone or via telemedicine, in collaboration perhaps with home health staff or not. And how do we think about anticipating some of these expected clinical complications like perhaps pneumonia, perhaps infections? Are we even thinking about treating each of those episodes? And if we are, then we can actually put emergency medicines into the house, which can be used in the event that we think someone has an infection. I also really stress there are excellent care managers or case managers. I mean, through our dementia caregiver group, we have an incredibly skilled set of social workers who can sort of help guide people to some of these case managers in the community if a patient or family don't have access to case managers through a primary care office or through their insurance company. And these case managers can really help, either long-term or for several months with how are we going to best coordinate care in the home. And they can be very good at also really identifying additional resources that can be brought to bear in the home. Again, for programs like mine, there are community-based palliative care programs that can offer more specialized palliative care support for patients and families when maybe we have some more complicated symptom management to deal with. Breathlessness, behaviors related to dementia, discomfort, and adding that group of people to the care team can often be helpful. And then again, I think it's really important that the goals of care are clear, and whatever those goals of care are, that they're articulated, documented in the chart. And then if it includes something that we call a MOLST form or medical orders for life-sustaining treatment, we help to protect individuals from intubation or resuscitation if that is their wishes. And those wishes are clear and that MOLST form is in the house. Just like I'm a big fan of, do we have the healthcare proxy? If a patient is clear about their wishes regarding intubation and resuscitation, the last thing I want is there to be a mistake around that intervention in the home. Judy? And so it's interesting when going through some of the literature, this was an interesting article for me back in 2016, that they looked at end-of-life care intensity for physicians. I love the groups they compared, right? They compared doctors, lawyers, and then the rest of the world. I think it would have been interesting to have divided the general population further, but they actually found that physicians were less likely to die in the hospital relative to the other two groups, and were also less likely to be admitted to the ICU relative to the general population. And so if we have an inside tract as to when care has become too burdensome relative to its benefit, I think this article kind of outlines that. Judy? And so just in summary, I love this quote, and people always joke. They always say, why do you always say that? I always say the goal is to keep the goal, right? What is our goal? What are our hopes and worries? Really, what do we want for the goals of our care? And then how do we stay focused on that? Because if that's what matters most, then everything else in healthcare, spiritual care, psychosocial care needs to bend to what matters most and is the goal of care for that patient and family. And so to that end, hopefully, I've been able to stress that palliative care is an interdisciplinary approach to care. It's the strategy. I'm kind of a military history buff. I break everything down into strategy and tactics, which sounds a little non-palliative care, but palliative care is really the strategy that begins with what matters most. And from that strategy, all the interventions fall into place, including hospice, when to transition to hospice, which is a tactic for those patients, individuals struggling with late stage disease and have a prognosis of less than 6 months. Again, it's an interdisciplinary team, incredibly important to have, as I always joke to people, I'm a doctor, I'm not a social worker, I'm not a chaplain, I'm not a psychologist. I really don't do any of those things very well. And so my little domain of suffering is only a small piece of the pie. So I really think it's important to, I can't do my job without the support and cooperative care of my colleagues in social work, chaplaincy, case management. It's just not possible, right? Because only then, when we're all working together, can we deliver the highest value of the highest quality care for that patient and family. And so even if a person with dementia has an unclear prognosis and can't access that hospice benefit, we can still be able to deliver at least some aspect of that care in the home through palliative care as best we can until we're able to unlock all the extra support that comes with the hospice benefit. Judy? And I think that's it. I wanted to get through that because there are always multiple logistical questions. It's an interesting question. There are often multiple logistical questions that have to do with my talk. So I wanted to leave enough time to get to some of those.
Thank you, Dr. Gallagher, so much.
Oh, thank you.
This is the time I invite people to begin putting your comments and questions, which I'll read to Dr. Gallagher from the chat. I'd like to start with a question which was on my mind from the beginning, and it's a big one. A big one, a tough
You're
one.
always hitting me with the big ones.
Always hitting you with the big one, but we did get you good coffee. Goals of care, and you always speak so eloquently, of course, about process. This is a process, and of course, what might be decisions in an early stage of a new diagnosis changes over time. And I think that's one point that is a really important take home for a lot of us, that decisions with the help of the team may change as the person living with an illness changes. What I want to bring up is, you mentioned many times that the healthcare proxy, a healthcare proxy is an agent, shares with the team what the goals of care and values are of the person with illness. And as you know better than everyone, a person with dementia often isn't able to share their goals. We have a lot of reasons for perhaps by the time the official diagnosis is made, for whatever has been the complication in the family, the cultural issues, people haven't had a chance to talk, and or relationships, and or who I've been my whole life, which is, I'm not going to tell you what I feel, whatever the reason. What if, when it comes to sharing with you what my father's goal for care is as a substitute for him, what if I don't know? So how can a family work with you and think about what he might want at this time? But I really had never had that conversation. And that could be for many different reasons.
Yeah, you're talking about my Irish Catholic family, I think, Barbara, is what you're talking about.
Talking about my Jewish family.
Geez. Yeah. Well, so I have to say that that's a great question. And I guess I'm struggling with the response because it's interesting. I'm trying to separate out on some level my work as a palliative care physician and how much actually my own mother and aunt taught me about this process, right? Because it was actually early on when my mother developed dementia, and both my mother and her sister, and I was the healthcare proxy for both. And it was an interesting and individual journey for both of them, right? Neither one wanted to talk about, what if your health gets worse? My mother completely shut down. So I actually had one of my palliative care colleagues go see my mother because I had no idea how to get her to talk about that. And I thought it was, classic, right? She as parents are protecting children, was my mother not talking about it because she was protecting me? And so my my colleague came out and she said, your mother is a hoot. And she said, as I was talking with her about, so, you know, when you look ahead, my mother said, oh, looked at her watch and said, thank you so much, dear. I know you must be busy. So I think we're all done, right? Yes, yes, Betsy had the, like, you know, this, but she did it with the watch, right? So if people are unable to have these conversations, how I start out trying to figure out how are we going to work together to understand what this person may have wanted, because we may never fully know, I think is to say, who was this person, right? Who was this person 30 years ago, 20 years ago, 10 years ago? What brought them joy? And while we can reframe meaning and joy throughout the trajectory of this illness, when we reach point C, right, we're left with really the core of who this individual was along 10 years, 20 years, 30 goes. What are we left with as the core of who this person is and was, right, to help inform us in that decision, right? And that's, I think, you know, for me in taking this journey, both with my mother and with my aunt, it was really about dignity, you know, preserving dignity, not prolonging the dying process, and preserving dignity as best we can. And they took me on their own journeys. And that's what I often say to people is like, you know, we can make a decision, and they will take us on the journey they're going to take us on and declare themselves. So that's how I sort of think about it.
It's very helpful, your messages. If we don't know an answer, let's reflect on who the person is. And that does, a number of times people begin talking and then they might remember, oh, but my father said such and such about Aunt Betty when she went into a nursing home, you know, and so you can start possibly recalling conversations that might help.
And sometimes I have people, I was like, you know, tell me your happiest moment with this patient. Tell me the funniest moment. Tell me the most challenging moment, you know. Who was the core of this person and how would they reflect on where they are today? And I have to say, you know, dignity and comfort and not prolonging the dying process seems to come up. Those are the big three, I think, that consistently come up.
Thank you. I have two questions. Number one, we'll start with what is a MOLST and what is a POLST? Please speak to that.
Yes. So a MOLST and a POLST, and we're going to be hearing a lot about POLST as well as, so POLST was the original sort of life orders for life-sustaining treatment, really as a way of how do we take this physician order regarding whether to initiate the process of resuscitation when someone's heart stops or to intubate them in the case of respiratory failure. How do we take that physician's order, which usually only hangs out in the hospital, right? It doesn't exist, it hadn't existed out there in the community. How do we make it exist out there in the community so that like an EMT, you know, running into a house really understands the conversations around these two interventions that a patient or family may have had, right? So the MOLST form is our Massachusetts orders for life-sustaining treatment, which is the same thing as the POLST form, which are orders for life-sustaining treatment. So all of those are really just the codification. It's a physician's order set. It's that beautiful fuchsia piece of paper that really outlines decisions around resuscitation in the event of a natural death, intubation, tube feeding, IV fluid. It's a little Chinese menu-ish on some level, but it's a set of physician's orders that then sit in the house so that the EMTs, if they come into the home, are clear on what decisions were made with regards to those interventions.
Thank you. And on a practical follow-up, because now, as we all know about the trajectory of illness and also the continuum of care, in one episode of an acute illness, an individual may well be in an emergency room, acute care, skilled nursing facility, and then home with home care. How can a family, and what should I be carrying with me everywhere? The question is, should I have 5 copies of the healthcare proxy? If we don't have an integrated system, and we don't always, or my relative may be admitted to the Beth Israel, even though, Epic is it. Anyway, could you speak to that? How many pieces of what do I take with me? And there is a question about should we give our doctors our HCP?
Absolutely. Everybody should know who the healthcare proxy is. So what I always say is, if there's a healthcare, it's almost like a little, if you have a healthcare proxy, if you have a MOLST form, and not everyone is appropriate, frankly, for a MOLST form, right? We use MOLST forms in the setting where they're appropriate, that resuscitation or intubation would actually not be beneficial, right? Those things may actually be beneficial early in the course of the disease, but I think as we get to late stage illnesses, those interventions are fairly burdensome relative to the benefit. So where along that trajectory of illness those decisions are made, that's when the form is filled out, right? So I think how I think about it is if a patient's going to be, even if they're not, for patients with advanced illness, healthcare proxies and MOLST forms should always live in the medical record of the health system where the patient is usually cared for, right? If there's a chance that a patient is going to be transported to some other health system just because of diversion, what I always say to people is that you should always have an envelope either on the back of the door, right, or on the pasted to the refrigerator, because that's where the EMTs look, that have a copy of the healthcare proxy and a copy of the MOLST form in them. You don't have to hang them up there and be staring at that pink form, right? Because people can find that distressing. But if you put both of those forms in an envelope and just write EMTs on it and tape it to the side of the refrigerator, then any EMT coming in will look at the refrigerator, grab that, and then transport your loved one with those forms to the other healthcare system. And then you just keep 10 copies of those forms in your drawer at home. And after they get back home, you tape the envelope back up with the healthcare proxy and any MOLST form if it's appropriate.
And for clarification, if EMTs enter the household of someone who chooses or family wishes to be DNI, DNR, and if there is not a MOLST, are the EMTs required to conduct a code call?
No, if you are the healthcare proxy and can report and present that form, you are the surrogate decision maker. And depending, for whatever reason, there may not have been a conversation lately. COVID has sort of complicated things. Many conversations and many forms may not have been filled out. But if the healthcare proxy is there, and if the healthcare proxy's medical decision in that moment is not to resuscitate, then the EMTs should honor that if you have your healthcare proxy form.
Okay, thank you. And to follow up,
but the EMTs, right? We need to respect, like, these guys and gals are, flying into people's houses, and it gets really, really, really confusing. And I never want to put one of my colleagues in a situation like the EMTs where they're going to walk out of house and wonder if they did the right thing, right? Yeah. So if that is the agreed to plan of care, let's not make it a crisis. I'm a big fan of, if we've thought about it, if we've talked about it, let's get that form done.
Right.
And nobody has to panic.
And here's a follow-up at MOLST question. I'm going to read it. If a MOLST is completed in early stages of the disease in conjunction with the patient was capable, who and how does it change as the individual enters in the later stage of the disease? So I think what's not clear, perhaps the questioner can write, are you wondering about what the decisions might be, or who makes the changes, or
No.
answer both?
Yeah. So no, this is very interesting. So if in that waxing and waning period, right, it's decided that beginning the medical process of resuscitation and intubation is too burdensome relative to the benefit, right, in terms of the quality of life, and that most form is completed. If for whatever reason a patient, say, falls and breaks their hip, right, or is found to have appendicitis, right, and surgery may be appropriate. Like in the case of the broken hip, surgery may be appropriate for pain management. In that setting, most surgical teams require a reversing of the intubation and resuscitation order. And the healthcare proxy makes that decision, right? Because it is allowing a beneficial intervention, right, that without it may cause more pain. Although depending on the stage of the illness, hip fractures don't always have to be fixed, but they are often fixed if they can be easily done. And then once the surgery is complete, on the other side, they've come out of the operating room, the DNR, DNI is again put in place. If someone, falls and has, aspirates on something that they're eating, right? Gets a Lego, is helping their grandchild take out a piece of Lego. I mean, how many, bronchoscopies are done to take out pieces of Lego from grandkids, and swallow something and has to undergo a bronchoscopy and be intubated. In that moment, the healthcare proxy may say this is a short-term beneficial intervention relative to the burden, in which case the intubation would be reversed, the problem solved, and then the intubation would be restarted. I think in the setting of dementia where we really don't think about reversing the intubation order is because many individuals that struggle with dementia will eventually lose the ability to eat and will often sort of have these low-level kind of secretions don't go down the right pipe and will often have pneumonia. But we know that's an expected clinical complication of late-stage disease, and intubation in that setting of known expected complications is likely not of benefit because it's just prolonging the dying process, right?
That's incredibly helpful, and that reminds me of what you said. A lot of what you might do as a medical director is to teach the family and to teach me about late-stage dementia and how swallowing is an indication of late stage, and that's where you are intervening in a different way than earlier stage.
Right.
Early stage, you may treat that aspiration pneumonia. Late stage, you may not.
Yeah. Yeah. And I think these are the conversation of what are you hoping for? What are you worried about? What matters most? And sort of understanding that, who is that individual and what quality means to them as they sort of work to reframe it through the progression of disease. Right?
Yeah.
I just wanted to quickly address, Susan had a couple questions in there.
Yep.
About,
we'll go back to creating a care team question. But
okay.
yes, there's a wonderful question about
question about some of the conversation starters like decks of cards. I people have used that. It's like the Go Wish, I think is what helped me. It's the Go Wish game. There are other internet options called Prepare for Your Care. There's another for those that are a little, there's a woman who actually did a lovely job. She lost her husband quite young in an accident, but she put together a website and does this how to prepare, but it's called Get Your Shit Together, for those that are a little more, sassy about the process. But I think those things, particularly the deck of cards, Susan, I think can be helpful for loved ones who are trying to find a way to bring this conversation up in a way that maybe children or grandchildren or brothers or sisters may be struggling with.
That's right.
I think to normalize the process is important. right? Like we get married, we think about having a will. We have kids, we think about having a will. We all have car insurance, we all have house insurance. Planning for these things, it, allows our families and loved ones not to have to make unknown decisions in the middle of a crisis, right? And that's how I always say, if we plan ahead, everyone is cared for, everyone sort of understands, even though some of the details may be different. The expected clinical complication comes suddenly and feels like it came out of the blue, but if we talk about it and we signpost it, plan for it, it's okay to touch. It doesn't feel quite so jarring, even though it feels sudden.
Yeah.
It's
Susan's other important question is, how do you assess capacity to change care plans in mid-stage dementia?
I think that's a big conversation, and it depends. I'm just trying to flip through. I think the question is, why are we thinking about changing the care plan midstream, right? Did a hospitalization happen? Did a person take a sudden turn clinically? Or is what mattered most to that person, right, who's been maybe able to articulate, I'm going to get to a granddaughter's graduation or a grandson's marriage, or there's some tangible point that my book needs to get published, right? And that once that bucket list is done and checked off, that for them, their goals of care have changed and you're shifting midstream, right? But I think, reassessing what matters most among that stage B, that trajectory of illness, it really is, how do we reassess and reframe meaning in our lives and quality of life, right? And that's going to evolve and change through that trajectory of illness B. And people can do amazing work in that space and reframe meaning. And at some point, then they're like, I've really wrung as much meaning as I can out of where I am. And now I'm really looking to change to a best supportive care, maximizing care in the home setting. And if I have an acute clinical event, acute medical event, manage me at home. If I get better, I'll get better. If I don't, then that's whomever's will, people will say.
Thank you. I have a follow-up to the capacity question, and Karen, not to worry, we'll get to your question, I promise, about team. About capacity, sometimes we think about it's all or none. If I have dementia, I've got to know my politics, I've got to know the date, the time, and all, and that's when I can tell you what my wishes are. Yeah. But yet, could you speak to that? I might not know the date of the day of the week. I might not know how to do math or do well in my MOCA, but might I still be able to tell my doctor or you what my wishes are?
Yeah. So I think capacity is a really complicated concept, and yet it's critical, right? And as Barbara said, capacity is a spectrum. It's really hard to think about a spectrum in certain care settings like hospitals, right? Because people will say people have capacity or they don't. I think for many settings, it's what do people have the ability to make decisions about, and what ability do individuals have to assent for things, right? So people can voice choice and not have capacity, if that's okay, right? But the thing about making, as a physician, when I think about how do I align my plan of care with this individual, is the individual who's struggling with memory loss, dementia, do they have the ability to retain any information and rationally manipulate it, right? If they don't, for complex questions, right? Many people, when they enter that sort of waxing and waning period, they may not be able to make complex medical decisions without shared medical decision-making of a healthcare proxy. right? So they may not be able to say, yes, I agree to go to open heart surgery, but they may be able to say, I really don't want that blood draw right now, right? And even though they may not, be able to consent to open heart surgery, they may be able to voice choice in terms of what's important to them. But I think consistency is also really important to pay attention to, right? That gets back to who is this person at their core. And when I see decisions changing all over the place, it implies to me people are struggling, right? And so we have to figure out why. Like they wanted this, somebody wanted that, then we're doing this. If it looks like it's a whole mix of chaos, it really means either we haven't done a lot of advanced planning, or this is really just an emotionally challenging period and we have to anchor people.
That's so helpful. And that's a perfect segue to emotional challenge. Our next person says, often people feel rather tormented about the idea that they should, quote, do everything possible for the person in their life who's dying.
Yep.
How do you help them feel that they are doing their best and that they are providing the best care, even when that means choosing not to do some medical interventions?
Yeah. Wow. If I could get doctors to think about that in a clear basis, we'd really be all much better off, right? It is so hard. And one of the things I tell many of our colleagues starting out is, doing should not be synonymous with caring, right? I think caring is holding the sadness of what may be a moment when people are dying, right? And to sit and hold, to not just do something, but to sit there with that moment of this may be the transition for my loved one from being chronically ill to transitioning to actively dying. And it's a very sad moment. And if it happens in a hospital, there will always be people saying, well, we can do this and we can do this and we can do that. Right? That's always my fear when individuals enter an acute care hospital with very late stage dementia, because that's what acute care hospitals do. They do things, and it's very hard to sit kind of with that sadness that this person who I've helped care for probably years is now in this moment that, while I've been planning for it, it feels very sudden, very raw, right? And so I've often had conversations and people will literally look at me like I have 5 heads about the concept of, do we treat, like when do we think about the burden benefit of antibiotics in treating recurrent aspiration pneumonias, right? And people will often look at me like, what are you talking about? And I said, well, every intervention is an intervention. And just because it doesn't involve a ventilator, or just because it doesn't involve resuscitation paddles, it's still an intervention. And it should be thought about in much the same way. What is the burden of this intervention? Quite low, right, in the case of antibiotics. But what's the benefit, right? If it's prolonging the dying process, how do we think about that? And for some people, that's every day that they're alive. It is a day that they're alive. And that's, we have to think about, does that align with this individual's goals? If it does, then one continues to treat. But if it's prolonging the dying process and that's not okay based on an individual's goals of care, then that's a conversation around, we sit with this patient and they will take us on the journey that they need us to go on. They will either survive this event or they will not. Right. And so I often say we need to give the patient a little space, and we can sit with them and sit in this moment, and they will tell us where they're going to go.
And that's a perfect segue to a question we had early. Should we get a care team together in my loved one's early stages? When should I begin? I now have a PCP and an excellent neurologist.
Excellent. 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 So I think I think as we think about those trajectories, the A, B, and C, and like who needs to be on your care team, having a trusted neurologist and PCP, turning to resources like the Alzheimer's Association, our wonderful social worker and dementia caregiver groups here, our MCI program, but really identifying in the community, what are some of the things we need? Do I need an elder, do I need an elder lawyer who's familiar with estate planning or financial planning in this space, right? So even though that sounds really odd, like a lawyer is part of your care team, but those are really important issues that are going to influence your plan of care in the months and years ahead. So as you start planning, people will rotate on and off the care team. Maybe you haven't thought about those things and you have an elder care lawyer help with some of that planning, and they roll off the care team and, enrolls your, rabbi or your chaplain or whomever is helping you kind of manage what might be some existential distress. So I think for a medical care team, you have your PCP, you have your neurologist, and then just sort of educating yourself around what are the expected medical complications, but also thinking about those other domains of suffering. Where am I struggling the most right now? It may not be in the medical, but where am I struggling the most, and how can I put together that team to help me think about really what matters most? What am I hoping for? What am I worried about? How do I reframe meaning? And then really looking to maximize your quality of life for the months and years ahead.
Actually, you just, among many things you're doing tonight, Dr. Gallagher, you just defined our mission, the mission of our program that Susan Rowlett and others talk about. The beauty of a team, of course, has to do with finding those people and navigating the healthcare maze. And that's really hard, if one is new to it. And that's where we hope we can help people understand who are the people in the community? What are your resources? Where do you reach out? That's a very tough path to navigate, don't you think, when you're new to the process?
I think it is, because we often think about, if I have a medical problem, I need like a doctor, right? And I'm often looking, if I'm helping to care for, an individual with dementia, and then supporting the family, I'm often saying, where's my social worker? Where's the person's, chaplain? How are they doing all this, personal and financial planning? And frankly, I'm probably not the most important person on that person's care team for many months or years, right?
Got it.
Yeah. There was one question, Barbara, early on.
Yeah.
From Ms. Simmons.
Well, Ms. Simmons something about HIPAA. She mentioned, I think Ms. Simmons shared with us the Conversation Project, and I'll look for more. Can you speak about the Conversation Project?
Conversation Project's great. That's another, gosh, my colleagues, they're so fantastic to work with. So several of my colleagues work on what's called the Conversation Project, and it is, at MGH, at the Brigham, Ariadne Labs, really talking about the serious illness conversation. And it's having the conversation. And, surprise, surprise, not all doctors and nurse practitioners, right, or other members of your care team may be comfortable having serious illness conversations. So it's kind of hard as a patient, individual, and family to kind of help prompt some of us to engage in these conversations, to be sure that we are listening to what matters most to you, because only by understanding what's most important to you and what matters most can we kind of partner with you in making up an appropriate care plan. So the Conversation Project is really about having that serious illness conversation, and it's conversations, right, at time of diagnosis, along the trajectory of illness, and really when it comes to that really sometimes complicated and hard feeling conversation around the transition to hospice. But it's serious illness conversations. Yep.
And they have a wonderful website, conversationproject.org. It's rich with information and Oh, thank you, Betsy. It's really quite terrific.
Yep,
Um,
yep. And also too, there was a question about a MOLST form, and there is at, mass.gov, if you type in MOLST, the mass.gov website also has a lot of good information around MOLST forms and what they look like. And they are, just to be clear, it is a physician's order sheet. So when, so it looks kind of scary to read as a layperson, but it is a doctor's order set. So, people shouldn't be sending you home with that to read over, because, it's a little,
you.
yeah.
You've already been educating us so much about who the person is and process. So I think I know the answer, but I'm still going to ask the following question, because there are times when a patient or the patient's proxy makes a decision about end-stage dementia, but I want that bypass surgery for my father, who I know would want to live or would want the surgery, or because that is who he is. Can you just speak to if and when there's perhaps a dilemma for the healthcare team in not agreeing or not feeling it's in the best interest of a person who can't speak for himself?
Yeah.
When there's conflict.
Yes, conflict. That's why I'm always a fan of start early and often. I think having these conversations along the way can be helpful, but I would also be mindful that people choose their healthcare proxies, right? And I think it's really, really important to have conversations with people about the role of the healthcare proxy. And is this person not able to make medical decisions for you? That's not that role, but are able to say what you would want if you were able to show up in the room and make those decisions, right? People will often make decisions as to their healthcare proxy is, and know that they will not act in a way that is consistent with their wishes. Some people do that. And I've had people say, I know this is my healthcare proxy. They're going to make decisions that I would never make, but they're my healthcare proxy. And that's the way of the world, right? And I think it is incredibly traumatic for the medical team.
Yeah.
Who really wants to avoid incredibly burdensome interventions.
Yeah.
Which they feel will not bring benefit, but we have to remember that benefit is really in the eye of the beholder. And so it can be very complicated, particularly as healthcare gets. We can do more and more and more, which makes it harder and harder and harder to decide at times. So I think conflict can often come from the heart and from best intentions, and we need to start in that place and try to figure out where the common ground is. And I think someone else spoke to conflict. I think presenting in interventions, if ultimately they are going to be agreed to, as a time-limited trial with very clear outcomes that would determine whether that intervention continues.
Yeah.
And I think that's where we struggle with that as a provider.
Yeah. I'm sorry.
I think conflict is hard on everyone, absolutely everyone.
Two important comments as a follow-up to Karen. And then I have a comment from Joanne. Karen says, just wanted to mention that along with getting a healthcare proxy, our elder law attorney recommended having a HIPAA authorization so that members of my loved one's family, brother, sister, son, have access to his health information. And that's right, Karen, you did mention that earlier.
Yep.
So HIPAA authorization, can you speak to how one obtains that?
Yeah. So you can, in terms of, it's usually for medical information.
Right.
So you can just ask any, from health information system or medical records to get a HIPAA form, and it usually has at the top who is able to request medical information. Also, there is the healthcare proxy form, which is pretty simple and doesn't need a lawyer to fill out.
Right.
You know, we have it. It just requires 2 witnesses.
Come here,
But
baby.
that's so there are a couple of things. There's the healthcare proxy is a pretty simple document.
Come here.
Then there's actually a durable power of attorney, which I recommend everyone have if they have a diagnosis of dementia. They have a healthcare proxy for the medical decision making. Then they arrange to have a durable power of attorney for financial matters,
Mhm.
right? That usually if you give them a blanket durable power of attorney, that covers all that decision making. Usually will cover the HIPAA stuff too, to be honest, or the copy of the healthcare proxy can. But you're right, the HIPAA will be needed for sons, daughters, whomever the individual feels would have
Thank
they
you.
would be comfortable sharing information. I think those are 2 really important things, having a durable power of attorney for financial matters and having a healthcare proxy for
Great.
medical matters.
Great. And we have an important comment question. I feel dementia has dimensions that don't fit some clinical definitions, for example, hospice.
Mhm.
Is there any movement to change this?
Yeah, it's a great question. It's one we struggle with immensely.
Hmm.
You know, the hospice Medicare benefit is, you know, it was enacted in 1982. I mean, when we think about that, that's 2 generations ago, right? 1982. And it was really at a time when healthcare was very, very different. And it was really put in place for most people with oncologic or cancer diagnoses.
Right.
And now we're trying to apply it broadly to any number of people. And I think dementia does sort of fall out of that territory. It's hard to change a piece of legislation. And so I think for the moment, we're just going to have to muddle along and hope that if we can get a palliative care team in there early and just be mindful of sometimes those transitions to hospice happen fast. And then a not insignificant percentage of people will, I listened to a very interesting, something called a Jerry Powell podcast. You can listen to actually, but we had used to say that people would graduate from hospice. So some people look as if they're in the throes of really that actively dying phase. And as we know, this waxing and waning course is really one of the challenges. They enroll in hospice and then, you know, 9 months, a year later, they haven't passed away and they get disenrolled from hospice. We used to say they graduate from hospice, but that can be another incredibly challenging part of the illness is some people will have to go on and off hospice depending on their trajectory of illness, which can be devastating, frankly.
Yeah. Before we end, so that others know, we'll ask Dr. Gallagher to talk about how one finds a palliative care team and contacts yours, but I still have one question. Could you speak to this past traumatic year, the pandemic? And we know that COVID has had a very profound impact on people with dementia and their caregivers.
Yes.
What could you just reflect on what you've seen and you are seeing? It's just been so dramatic, be it one is at home or in an assisted living or in a skilled nursing facility.
Oh, you know, that is it's incredibly difficult to reflect on in a very short period of time. I think suffice it to say that that social isolation is a devastating thing. Whether one is struggling with a diagnosis of dementia, or you're a caregiver or family member helping to support that person through the process. I think this past year has shown us that the importance of human interaction in maintaining cognitive skills for as long as possible are huge, and for actually decreasing caregiver stress and burden.
Yeah.
So I think that speaks to it takes a team.
Yeah.
Right. And to be able to, for caregivers, be able to say, I need time for me to be able to take care of you, and finding ways to have that happen. And then, you know, appreciating that for the individual with dementia, it's accelerated the course of illness in many people we care for.
Yeah. And I know many of the people who are here with us tonight, you've no doubt discovered resilience that you perhaps didn't know you had, because you're here, you've made it. And
Mhm.
we have great respect for
Yeah.
your stamina and your creativity.
Absolutely.
Everyone must be thinking, or I am too, so I want a palliative care doctor. Actually, I want you.
No, you
Can
don't,
you speak?
Barbara.
Yeah,
You don't
I
want
do.
me, Barbara.
Not yet. But can you speak to where how your team can be accessed? But I know that there are geographic regions, and how I might look elsewhere if I don't fit into your region.
Right, right. So just like with hospice, many of the community-based or our home-based palliative care programs are, they're sort of looking to support people that need that subspecialty, palliative care, either social worker, nurse practitioner, or doctor. For our program, I help to collaborate with 4 incredibly talented nurse practitioners and an incredibly talented social worker who do the bulk of the work. I just take the credit in conversations like this. But so I will work with them and then see patients as well as I need to cover. So we are available within, I just say 128. And you can either talk with your neurologist or talk with your primary care doc. But if there's, a clinical change, things aren't going well at home, there's been a hospitalization that may have shifted goals of care, our team, our nurse practitioner and social worker can come out, do a home assessment, help perhaps clarify and elicit what matters most, and can sometimes actually make will make suggestions regarding maximizing medical management in the home, in collaborating with, usually people have multiple providers of PCP, maybe a neurologist, a cardiologist, so they can kind of help prioritize who does one need to go to and how do we maximize care at home. If you're not within that catchment area, and sometimes we will do just one visit, sometimes we'll do a handful of visits to help kind of set up that plan of care for the coming months. And then we'll rotate off the care team, and then maybe 9 months from now have to rotate back on for a period of time. If you're not within that geographic territory, then there is a website called the Hospice and Palliative Care Federation of Massachusetts. I think we can
Put it in chat.
I can put that in the chat. Now
Okay.
Barbara's just messing with me. So
Yeah. Thank you.
Hospice and Palliative Care Federation.
Great.
The
Great.
Hospice and Palliative Care Federation of Massachusetts is a nonprofit. They do some great work. And on that website, there's something called a hospice locator. But what you're looking for is palliative care. So what you can do is you can go into the hospice locator, and then you can pick by town, like where the individual happens to live. And then there's another drop-down menu about types of programs. And one of them is adult palliative care. And you can click on that one and you can see which, and it's usually community-based palliative care programs are often run either out of a home health or a hospice agency. I think we're one of the few community-based palliative care programs that's run out of a health system. I'm trying to think in the state of Massachusetts. I think we might be the only one, actually. Nope, it may be the BI, but that's a way to actually look. Though that'll be a hospice or hospice or home health agency, but you'll be able to see who else in that area provides that care, and then you just call them up and you sort of, you can see whether it's a good match.
And if my relative is cared for in the Mass General Brigham network and in your geographic region, what is the process of referral to your team?
You could say to your PCP or neurologist, I think it would be helpful to have someone come to the home and sort of help us work through some of these, I don't know, are we maximizing their care correctly at home? I need help sort of clarifying this conversation. And the primary care doc would just put the referral in through the medical records to our program, and then our coordinator would call and look to schedule an appointment.
That's great. Dr. Gallagher, you are now off the hook, but you have been
Off the hook.
You've been speaking eloquently and passionately for an hour and a half. And on behalf of the Dementia Caregiver Support Program, I forever and will ever, we are all grateful to you. You've taught us a lot. And for everyone to know, in about 10 days, the video of this program will be on our website. So when you want to take a look again and refresh your thinking or share with others in your family, it's available for you. So I thank you for your wisdom. You want to speak?
No, and I did, I think these types of conversations can actually be very helpful for me as well. So if any of you have questions or questions that didn't get answered, or content that you think would be important to include in another conversation I have like this, that you think individuals in your position would benefit from that I didn't include, please give that feedback to Barbara and Judy and Susan, to be sure I can improve.
Absolutely. But so that we're getting lots of thank yous. I feel much better informed and appreciate all that went into this. Thank you, Dr. Gallagher. Awesome presentation. This was really very helpful. Thank you, thank you, thank you. We'll still send you the questions, but thank you. And you've made a big difference. And to our attendees, I again feel, please send us your questions, which we'll forward to Dr. Gallagher. And thank you all so much. Just want you to know, 3 weeks in the month of May, on May 18th, actually Dr. Erin Stevens, one of our colleagues who used to work here in the Division of Palliative Care and Geriatrics, and now I think lives in Iowa. She is a fabulous...
Barbara, she lives in Ohio.
Ohio. Oh, yeah.
You guys, don't miss Erin. Don't miss Dr. Stevens. I reach out to her all the time with my dementia questions. I send her all sorts of stuff. She's great. Don't miss her.
And she's going to be talking about understanding some normal memory changes that occur with aging versus when the situation is a possible dementia. So she is great, even though I don't know where she lives. She's wonderful. So thank you all. Thank you, Dr. Gallagher. And everybody, enjoy the warm evening. Bye-bye.
Good night, everyone.
Thank you. Good night.